Um, so before we begin, I know a lot have heard, and today we want to acknowledge that today is the National Day of Observance of COVID-19. And remembering back on this day is when the WHO did declare this as a global pandemic. We could see that it was coming. They wanted to officially declare it. And making that declaration is not a simple task. It means it's dealing with a wider area of the world, and they had assessed that, and we had seen it escalating over the week ahead of us, before that one, fairly rapidly. It's also to commemorate the people who lost their lives with the disease during this time and the impacts it's had on everybody. Everybody, and some of us has more than others. It's been a tough time. It's been a different time, and it's been a year long, and we're over a year. And when we entered the pandemic at that time, I know that we had anticipated what might be coming down the road. I was discussing with Dr. Brown that when that day, we already saw the numbers rapidly escalating in Europe, and where we've seen numbers in, for example, Italy went from just in the few hundreds up to 4,500, up to 12,000 in a matter of just a week and a half. And we saw what was happening there and the struggles and issues they were dealing with. And we knew that was coming our way. And we were looking at and saying, how are we going to, we've been prepared for this, we know about it, and how are we going to mitigate the impacts? Because we want to say is that how do we keep down the morbidity and the mortality of this? How do we keep our healthcare system intact? How do we keep our society still running? Because some places it fell into disarray, and that can do that very quickly. So we saw that coming down the road, and sometimes you see the numbers that are calculated by our modelers, and people think those seem to be exaggerated. They're not exaggerated at all. They're based on very sound analysis, and those are forecasts that are quite real and can happen if we do not do the steps we do with our public health measures, our personal steps, our collective steps, our activities around limiting mobility and movement, and that we've done very stalwartly over this last year. Well, we've had over 300,000 cases. We were expecting fully by this time to have close to 3 million cases. That's what we were facing, and that's what the data showed. This has been the result of all the work over the last year, a lot of work, a lot of effort on everybody's part. Healthcare workers, healthcare providers, first-line people, first-line responders, you, the public of Ontario, in all your different areas, full government response. This has not been any small task, and the fact that we have 300,000 at the moment, over 300,000 cases, not over 3 million cases, is an evidence that of what you have achieved over this past year. We can talk about it a bit now because there's an end in sight. We're working on our vaccine, which was predicted to come in a year and a half. We're a bit early, not too far off, but we're moving stalwartly in that direction. So here we are a year later, and we're looking at that and what we have learned. But at the same time, as you're going to hear from the modeling data, we are not finished yet. We are still facing new issues. We're still facing variants of concern, and Dr. Brown will give us some updates on that data. So while we are well into a year and 14 months of pandemic, we expected to have 18 months of pandemic. We still have another 4 to 5 months of clear, hard work ahead of us to keep our numbers down while we do the vaccination, while we get caught up, while we protect you, the citizens of Ontario, your loved ones and family members. And just with that, and so thank you for all you've done. Our condolences to those who have lost loved ones. Some areas of the world, they've lost large percentages of their families and young people as well. And we're concerned always about those aspects. So while we have achieved lower than what we expected, nevertheless, this is a pandemic. This is a real thing. It has real impacts. That's why it's global. And in different countries, it's having immense amount of impact in various populations. But thank you to the work we've done here and what you've done, we have been able to keep it down to some level. We'd like it even lower. We would have liked it lower. And so we're always trying harder. So let's look at the data now. And I'm going to hand things over to Dr. Brown and give us an update, and I'll have some comments on the data today. So over to you, Dr. Brown.
Thank you, Dr. Williams. Like Dr. Williams, I just want to note that today is the National Day of Observance for people who've died during the COVID-19 pandemic. As Dr. Williams noted, Ontario has lost at least 7,000 people to this disease. And that's thousands of families in every part of this province who've experienced a real loss in the last year. And it is clear that the cost of the disease will continue beyond the pandemic and will be as inequitable or more so than the pandemic itself. We spent a lot of time in these briefings talking about numbers and curves, and we will do so today. But today is a day to remember that every single number is a loss. Every single number represents suffering and grief. And I know that we always say that we're all in this together, but I know that we've often also had to suffer and grieve on our own over the last year. And so I hope that the Day of Observance today gives us all a chance to lend each other strength in the way that each of us needs. And I hope that as we move towards what is hopefully the last stage of the pandemic, that we're able to move through it as one province. Today I'll share data that shows our progress through what we called at the last briefing a minefield. We've had clear success with vaccination in long-term care homes. Deaths and cases are at a very low level now in these homes. And there's emerging evidence that vaccination not only reduces the risk of death and hospitalization, it also reduces the risks of catching and passing on the disease. That evidence, if it holds, is profound. It would mean that each vaccine protects the person receiving it, and it can help others who have not yet received it by reducing the risk of transmission. Continued progress on vaccination will take us through that same minefield more quickly and more safely. And the farther we can press down our cases, particularly among those most likely to get sick or to transmit the disease, the more effective our vaccination campaign will be. Now, our experience in long-term care homes was a success. We're now moving the focus of our vaccine programs out of long-term care homes and into the community. And we know if we're smart about how we focus our efforts on communities where the vaccines will have the greatest immediate impact, we can dramatically reduce the toll of COVID-19 and move more quickly towards a safer province. If we use the tools that we have to reduce risk as much as we can, as fast as we can, we will end up protecting all Ontarians. So the vaccines work. They protect you, and it looks like they protect the people around you. I want to encourage anybody who's unsure about the vaccine to talk to your family doctor, talk to a primary care nurse, talk to your pharmacist. They will give you advice that works for you. But despite the success on vaccination, there is still much danger ahead. Mobility is increasing, and with that, the risk of greater spread and of being exposed to someone with COVID-19 and catching the disease yourself. The proportion of cases that are new variants of concern is also increasing steadily. So this means the risk of being exposed to someone with the disease has increased. It also means that the risk of catching the disease has increased. We can see early indicators of these dangers. 24 out of our 34 public health units have seen an increase in case rates over the past 2 weeks. And of these, 14 public health units have seen growth of more than 30%. Now, this growth sometimes is in very small beginning numbers, and so it does not represent huge numbers yet, but this growth isn't random. It's a function of how loosening public health measures, increased mobility, and growth in new variants come together. Some of our largest communities that maintain strict public health measures have kept cases flat or seen cases drop. But cases are rising in other communities, and our cases are now substantially above their level 2 weeks ago. This means that we still face a very risky situation. So we're still in the early stages of our journey through the minefield. Our intensive care units are still under pressure, and a sudden jump in admissions to these units will put our hospital system under immense strain, and this will affect all patients who need care. 1 year in, as Dr. Williams has said, controlling COVID-19 is not a mystery. When we see these increases, we know exactly what to do. Masking and social distancing are a safety net and will help keep spread down. Although it's hard, and I know that everyone is at their limits, just a bit more discipline with masking and distancing will help bring cases down, and more importantly, hospitalizations and deaths down. We know the vaccines work, especially if we deploy them strategically, and they'll do an even stronger job if we can keep cases down. Finally, it's time, as we keep the goal of a great summer and the eventual retreat of the pandemic in front of us, to think about repairing our health system. Today we'll share data that shows we are building up a significant backlog of care. This is true for surgery, for screening, and based on emergency department admissions data that we presented 2 briefings ago, it's true for mental health and addictions. This backlog reflects 2 distinct problems. The first, the amount of care that we've had to postpone through the crisis. And second, the number of patients who appear to have stayed away from health care even when they needed it. Combine this with a likely rise in chronic disease associated with unemployment, and our health system will need to be ready to handle a prolonged and substantial surge in the demand for post-pandemic care. Let me be clear. This is not a question of ignoring COVID-19 patients and focusing on other patients. When people get sick, regardless of the cause, our hospitals will take care of them. But we cannot move patients through hospitals that are filled with COVID-19 cases. And we cannot convince people to seek care when they are concerned about becoming infected themselves. But we will need a brave plan for rebuilding and strengthening our health system as we come out of the pandemic. This is the kind of reinvestment and plan that countries usually think of when they're repairing from a war or after a natural disaster. And with all that as background, let's get into the numbers. And my apologies again, but when we do present the slides, the sign language translation will disappear. It will return immediately after we finish the slides. If we could put up the slides, please. Great. Thank you. Here we go. As usual, we'll start with the key findings. Vaccination in long-term care has paid off. This focus has allowed us to really dramatically reduce cases and deaths, both in residents and staff who work in these homes. But otherwise, progress has stalled. Declines in community cases and test positivity have leveled off. Cases are increasing in most public health units as we see mobility rise. The variants of concern continue to spread across Ontario, and our ability to control the rate of spread will determine whether we return to normal or we face a third wave of infection. We know it works. Continued masking and distancing are essential to controlling variants of concern. And we've learned over this year that preventing the rise of cases is easier than flattening the curve. Our behavior over the next few weeks is critical in determining the quality of our summer. Now, as we said in introductory comments, high volumes of postponed care, missed screening and preventive care, and other issues mean that there will be a substantial and prolonged surge in the need for care across sectors. Our actions now will actually determine our ability to access care later. Finally, controlling cases, increasing vaccinations where they will have the greatest impact, and accelerating vaccinations overall are how we're going to beat the pandemic for good. Let me start with the good news. This is a chart that we present every time. This is a chart showing deaths and cases in long-term care homes. When we put together this material yesterday, we had the very nice situation where we had seen no resident deaths in the last 5 days. We have now seen one death, which means that we have one death in the last 6 days, which is a profoundly different statistic than we saw at the beginning of the year. We are down to 25 homes that have outbreaks involving residents, and 13 public health units have no homes in outbreak right now. And although we did exceed the death toll in wave 1 during the second wave, it has really truly flattened out now, and it is in a much better situation than we were anticipating when the disease started to spread through. So vaccination has really paid off in long-term care homes. But as we talked about again, mobility is starting to increase again. You can see here the blue line at the bottom is the line for Ontario. You can see that it's continued to increase over the last couple of weeks. This is really after a flat period of mobility following the winter holidays. And it's this mobility, as people encounter each other, as people move around and spread the disease to each other, which is particularly problematic for controlling the spread of COVID-19. You can see here a little different presentation of the changes in cases across time in our public health units. The yellow bars represent average weekly cases in February 21st, the week of February 21st. And the blue bars represent the same statistic about 2 weeks later, on March 6th. What you can see is the majority of public health units have seen an increase in cases over that period of time. You can also see, though, that the majority of public health units are now over the restrict level in terms of the total number of cases. So we are seeing an increase in cases. An important thing to consider, though, is what is the role of the new variants in this? And so the next 2 slides that I'll show you really reflect data from Ontario. The red panel, or the red graph on each of the slides I'm going to show you, is the estimated rate with the new variants of concern. And the blue panel, the right-hand side panel, is the estimated rate or the estimated statistics that we're seeing with early variants in Ontario. I think it's important to note that what you see is a decline in the early variants, the types that were in the province when we started to deal with this COVID pandemic, the earlier strains, the ones that have come out of Wuhan or other places. These are the ones that we're very much able to control, and you can see us coming down out of the second wave with that decline in cases. The red is the new variants of concern, the variants that originally were identified in the United Kingdom, in South Africa or in Brazil. And you can see that at the same time that the early variants are declining, the new variants are increasing substantially. So you can see the effect in Ontario itself of the new variants of concern. Really, as was noted by one of my colleagues earlier on, two pandemics playing out, one with the early variants under control and one with the new variants not under control. And we talk about the R statistic, the reproduction number. This is the measure of how contagious the disease is. Really, how many cases or how many people do you infect when you have the infection? Again, with the blue line, you can see that the R is consistently under 1 after we implemented the public health measures. That's good. That shows that disease or that pandemic coming under control. The new variants, though, as you can see here, are consistently above 1. This is the data from yesterday. The updated data is now on our website for the Science Advisory Table, and you'll see it updated daily. It is climbing still for the new variants of concern. So cases are up. It seems to be strongly associated with the new variants of concern. What about positivity? And you can see here that positivity, the percentage of tests that are returned positive, that say that there is COVID-19 disease, you can see here that that has flattened out in Ontario. That's the black line. And you can see it climbing in a number of public health units. So cases appear to be rising. Positivity appears to be rising. The third thing that we need to look at in all of this is, let me just get the right slide up, the testing episodes. So how much testing is going on? And testing is solid. We're at a consistent level of testing, as you can see here, that black line, which is Ontario. So when we see cases up, when we see positivity flat or increasing, and we know that we're actually kind of at a flat or continuing sort of strong level of testing, that says that these are likely real increases in COVID-19 cases. Let me now take turn to what this means in terms of projections. Because of the rapidly changing situation with the variants of concern, we're only projecting forward scenarios for the next 3 weeks. Typically, we'd look to 4 to 6 weeks to try to give a longer look ahead. There is a lot of uncertainty right now, and with that, as Dr. Williams said, a lot of risk and a lot of danger. We presented 3 scenarios here. Each of these scenarios are sort of selected from about 15 to 25 models that we have at any one time running with different sets of assumptions. I will say these are not selected because they are atypical. They're selected because they reflect what we see across all of these different models, and so that we see very consistent results. If you look at the green line, this is the case projections in the low, or what you might call the optimistic scenario. And in this scenario, we are assuming that there has been a low increase of variants of concern over time in Ontario. So when we're doing estimations, we're assuming that the total prevalence of the variants of concern is at the low end of what our estimates might say. It's assuming low transmissibility of variants of concern. And so when we look into the scientific literature and we try to understand how much more transmissible they are, we take the low end estimates of that increased transmissibility. And we're assuming a very, very cautious relaxing of public health measures, very much in line with the framework. And you can see under that sort of, let's call it best case or optimistic scenario, there's continued growth, but it is relatively small growth in the number of cases over the next 3 weeks, really topping out at the end of those 3 weeks at about just under 2,000 cases. If you look at the medium scenario, which obviously relaxes some of these assumptions, assumes a higher prevalence of the variants of concern, higher transmissibility of the variants of concern, and more aggressive relaxing of the public health measures, you do see that cases start to increase substantially, up to 6,000. And then if you get into a worst-case scenario where there's a substantial immediate relaxation of public health measures, you can see that the rate of cases grows much more substantially. For anyone who kind of follows these briefings, this won't be a surprising finding that it is heavily dependent on the public health measures. It's heavily dependent now on the variants of concern, which are a new risk. But the other thing I should note is that we're only looking out 3 weeks here. Vaccination will start to have an impact on case rates. It will start to have an impact on the rate at which those cases convert into hospitalizations or deaths. But given where we are in a vaccination progress, that's really still 2 or 3 weeks out itself, at least, to see that materializing in the data. As we get more information and we can adapt our models, we'll continue to project out and hopefully project out more into the future next time. This next slide shows you the get to the right slide there. Hospitalizations and ICU occupancy. and how they are changing over time. I think it's important to note a couple of things here. There has been a substantial decline in hospitalizations, which is now starting to level off, but we have not seen the same decline in ICU occupancy. So part of this is because we see very sick patients, some very sick patients staying very long in the ICU. There's a long tail there of length of stay, which means that those beds are not free to care for other people, and they are in ICU beds because they require that level of care, not because of any other reason. But this means that the occupancy of the intensive care units is not emptying out as quickly as we'd hope it to be, which creates a greater strain or less resilience within our health system. And then there is also this question that is still being debated, but I think is starting to resolve in favor that at least the B.1.1.7 variant, the UK variant, does create a more severe form of the disease. It's something we'll need to watch very carefully, and we'll need to understand with all of the new variants of concern. But you will see continued strain on our intensive care units, with the result that if it does get to be more strained, you will see real challenges in meeting the care needs of people. And here you can see, as with cases, the same scenarios apply to projections on ICU occupancy. Again, with that optimistic scenario, if we're able to really keep control over the disease, you'll see only a small increase in ICU occupancy to just under 400 beds occupied at the end of 3 weeks. It's important to note that this is not a small increase, and thus something not to worry about. This is a small increase on top of an already strained system, which creates a challenge in access to care. And obviously with the less optimistic scenarios, the medium or the high case, you can see us getting between 550 and 650 intensive care unit beds occupied, which will really present significant challenges in meeting even the most urgent needs for care in Ontario. We've often presented measures of the backlog in care, and this here is a simpler presentation of the surgery backlog. You can see that with the shutdown of hospitals in March 15th, really trying to control the spread of the disease as we were learning about it, as Dr. Williams said, in that first few weeks as we're learning about what this pandemic meant. There was a substantial backlog in surgical cases that built up, but it's important to note that that backlog has continued over time to increase. This is because of limits on intensive care unit capacity. It's on limits around how we make sure that we move people through hospital very safely. But at the end of the day, what it means is that come at the end of this month, we are 230,000 roughly cases backlogged. We are working hard, I know, across hospitals in Ontario to make sure that the most severely ill people get the care that they need. But these are not what we might consider unnecessary or frivolous surgeries. These are surgeries for care that people need, where there's a referral or a decision with their physician to go for surgery. And so delaying surgery really does lead to an increase in morbidity and can really lead to more worrisome impacts as well, as people are unable to access care in a timely way. But this is not limited to surgery. This extends out to screening and preventive care as well. Here we're showing cancer screening volumes, and you can see a substantial decline in cancer screening volumes across really all different modalities for cancer screening. It has started to come back up again, but is not yet at pre-pandemic levels. And it's important to note again, although some of these cancers do grow very slowly, that when we miss screens, we miss cases, cancers progress, and again, we will need to deal with the consequences of this in terms of increased morbidity. And so important to note here that we see a backlog really across the entire patient journey. We see this backlog building up across sectors. And if you think back to some of the emergency department data that we've showed in the past, there are people who are not coming into emergency departments and other sources of care when they need it. It's almost as if there's a disappearing patient phenomenon, to use a term one of my colleagues uses regularly. And this really reflects, again, now increased need for care that will start to build up. Match that with the health consequences of unemployment. We know that we're going to be facing a substantial increased need for care post-pandemic for a wide range of conditions. And as Dr. Williams and I were talking before the press conference, we still are learning more about what long COVID and the long-term consequences of infection with SARS-CoV-2 means for people. That can further add to the burden, what will be an unmet burden of need for care in the future. Continuing on, let's look at vaccinations. You will have seen that today yesterday we passed 1 million vaccinations. When we think about terms of people who've been vaccinated, that's a slightly less number because some of those people are getting 2 vaccinations. But we're starting to get close to 700,000 people across the province who've received 1 vaccine. And we're now getting closer to 300,000 people who've received a full course of vaccination and thus are protected to the extent that the vaccine does. And in this next slide, I'm going to show you some data. This is not Ontario data, but it is important data that we referred to in the introductory comments. This is evidence out of Israel that shows that vaccines not only protect against death and hospitalization, basically make the person more able to resist the consequences of infection, they also help to reduce infection and decrease transmission, which really means at the end of the day that the vaccine is both protecting people and protecting people around them who have not had the vaccine by reducing transmission. So you can see there's substantial reduction, more than a third, getting close to a 50% reduction after 3 weeks after the first dose between unvaccinated, that's in the red line, and that blue line much below it in terms of vaccinated individuals. So more good news on how vaccines can help protect us. I'll finish here again on the key findings. I want to make note that just, vaccination in long-term care has paid off. Progress, unfortunately, otherwise has stalled. If we are able to continue masking and distancing, to continue with public health measures where they're necessary, we'll create a much better context for vaccination. We will also really make sure that we control this pandemic and bring us towards the, I think the promise that everyone wants of a much better summer, much better even perhaps than last year. And our actions now really do determine not only the progress against the pandemic, but our ability to access care later. Controlling cases, increasing vaccinations where they'll have the greatest impact, no matter how provocative or challenging those statements are, and accelerating vaccinations overall are how we'll beat the pandemic. And I'll just finish here to note some of the many contributors who've put material together for slides today, which span several universities across Ontario, different research institutes and agencies. And with that, Dr. Williams, I'll turn it back to you. Thank you.
Well, thank you, Dr. Brown, and much to think about and to focus on. Looking at our data in Ontario since the last report on Monday, we have seen another 3,593 cases of COVID-19. Tuesday, we had 1,185 cases. Yesterday, 1,316 cases. And today, 1,092. And I would say the data looks like it's going to be back up again tomorrow. Our 7-day average of cases is 1,252. That's up from 1,064 1 week ago. While we're reporting an additional 32 deaths since Monday's update, the 7-day average of deaths has decreased slightly to 12, down from 15 last week. The number of patients in hospital and intensive care has remained fairly stable, with 680 people currently hospitalized and 277 in ICU. In terms of testing, our volumes are staying up. We did 60,619 tests were processed yesterday, with a positivity rate of 2.4%. As far as variants are concerned, there are now 1,025 confirmed cases of variants of concern in Ontario. Majority of these, 956, are the B117, the so-called UK variant. 41 are the B1.351, or the South African variant. That was up 2 from yesterday. And 28 are the P1, or the Brazilian variant, which was an increase of 1 from yesterday. There are an additional 6,513 samples that have screened positive for the 501Y mutation and are waiting for delineation. So in conclusion, these issues are before us. The variants of concern are there. In this morning, we have activated the emergency brake in the Public Health Sudbury and Districts region, moving them into the gray lockdown due to a number of outbreaks that have accrued very rapidly in the area, including increasing transmission of variants of concern in high-risk areas within their community. is clear demonstration of why in Ontario we're going to have to be very careful and move as quickly as we can to try and curtail and limit, especially these variants of concern that can rapidly impact wide parts of our population, even as we wait for vaccinations to occur. So we're urging again everyone to stay at home, no matter where you are in the framework. If you don't need to go out, don't go out. If you do, for essential reasons, just keep them for that, not just wandering around. We're still finding, unfortunately, in areas where we have outbursts, even in our green, yellow, and red areas, records from public health of people gathering for social events, not taking precautions, and not doing the proper personal behavior. We can't emphasize that that's just really a bad decision. At this time, especially we've heard from walking across the minefield, you are really trying to walk without guidance in the minefield if you don't take these precautions. So you need to do that. So let's keep at the task. Let's keep working forward to get the vaccines out and keep everybody protected. So with that, I'm going to hand over to the media for questions.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
Your first question comes from Lorenda Redekop from CBC News. Lorenda, please go ahead.
Thank you. So looking at your modeling, and I know we've been hearing about the emergency break, is there the possibility that regions that are considered in the gray or lockdown could be moved further and go back to stay-at-home orders?
So we are looking at what we need to do in those public health measures and steps. The stay-at-home order, as we know it, was a product of the emergency order under the EMCPA, the Emergency Measures and Civil Protection Act. And so in order to implement a stay-at-home order, as we knew it in the past, that would have to be declared again. So that's not available to that extent. It does mean that we're asking people to stay at home anyways, to do that as a matter of precaution, especially if you're in a gray lockdown in an emergency brake situation, because you know, in the analogy of cars and that, things are accruing fairly quickly in front of you. You need to take precautions personally very much in those areas until there is a release from that, and when your medical officer of health, combined with consultation with my office and with others, can pull that and lift that off again with the direction of Cabinet. So no, we can't just institute it in the same way as under the EMCPA, but we can take steps with different orders to mimic that. And most important, that the public would take these sudden steps very seriously because they can see it accruing in their own jurisdictions.
Follow-up?
I feel like you didn't quite answer. I was trying to get at, is that a real possibility when you guys are talking about the progress is stalled and you're looking at, our actions over the next few weeks will determine our summer. So what are the possibilities here?
Okay, I think I see where you're going. I think, can the province move again to go back into a state of emergency? It certainly can. And the Cabinet is quite wary and concerned about these issues here. They're watching it, and they and all the decision makers, including myself, would like not to have that happen. We'd like to be able to continue everybody to do what they should do in all levels, so we can follow some of those better curves that Dr. Brown had alluded to and keep the varying concerns under control. We can do this. It is possible. As Dr. Brown said, you know what to do. We know what to do. We just need to do it again, and do it consistently. But if there needs to be a state of emergency again, that's something that can be covered off. It's something we would rather not do, but if we have to do it.
Next question.
Your next question comes from Anthony Fury from Post Media. Anthony, please go ahead.
Hi there. Thanks for taking my question. Gentlemen, I wanted to get your thoughts on a Statistics Canada report that came out yesterday. There was the one about the undetected cancer screenings, and I appreciate you've already made some observations about that, but there was also numbers in the Daily looking at 2020 mortality and excess death data from last year, and they concluded that more recently, I guess in the second wave, the number of excess deaths has been higher than the number of deaths due to COVID-19, and these deaths are among younger populations, and they say that this suggests factors including indirect impacts of the pandemic are now at play in those, I guess, consequences of lockdowns and so forth. Can I get your thoughts on that, please?
I'll ask Dr. Brown to comment because he said they were looking at other aspects related to COVID beyond the infections of COVID patients, the surgical backlog, the delays in cancer screening, and people being assessed later. There's other ones that we were related to, and we've talked about those before, aspects related to drug overdoses, unfortunately, resulting in deaths, and other factors that are part of this. So these are very important things to raise, and we need to be aware of and try to mitigate the impacts of those as best we can while bringing down the COVID. That's why it's so important, besides the protection with the vaccination, so we can refocus on these other ones even further, because this will continue to linger and have an effect, as Dr. Brown has alluded to. I'm not sure, Dr. Brown, if you have some further comments on that.
Sure. So thanks for the question. So we see deaths from COVID-19, and we see excess deaths, and we see that same pattern of both high COVID-19 deaths and high excess deaths in almost any jurisdiction we look at. What's been interesting is just reading some of the material recently about, say, excess deaths in the United States beyond COVID-19. It's a very high level there as well. And so it seems that everywhere the pandemic is having both an impact on death directly from infection, but also death from other causes. It seems to be, at least looking at that U.S. data, to be somewhat similar, regardless of the different policy positions or different types of lockdowns that jurisdictions have pursued. What does seem to be clear is that jurisdictions that have taken very substantial early action seem to be coming through it overall much better in terms of deaths from any cause.
Follow-up?
I also wanted to ask, you mentioned having a good summer and perhaps a better summer than last year. A lot of child welfare advocates, pediatric experts are talking about trying to get as normal of a reality for kids as possible. Is it fair to assume that outdoor children's sports, baseball, soccer, and so forth, you'll rubber stamp that to continue this summer?
Well, there certainly is a lot of pent-up interest, and we all have that. We're looking at our vaccine programs rolling out. We're trying to get all our rates down. And of course, in those congregate settings in there, we're seeing that some companies are looking at vaccines for 12 to 16-year-olds, and we're interested in that. I believe some are looking at even younger age groups, so we would be very interested to see how that will impact us. We would like to see a lot of resumption of activities in the summer. In the latter part there, we're having our public health measures table is looking at that. What would be the proper checks and balances to make sure, because as Dr. Brown has alluded to, we're seeing some concerns in the variants of concern where younger people are being impacted significantly. So we can't say where in the first wave that this is more of an issue dealing with the more older and elderly population. It may have wider effects in there. So I would say we're hoping. We have to stay tuned and watch the data very carefully. Keep getting the vaccinations done. Wait for new technology. And it would be great to have a child vaccine as well. But these do take time and proper studies with care and precautions in place in that. So we're looking for that summer. And I think a vaccinated Ontario is very much different than an unvaccinated Ontario.
Next question.
Your next question comes from Matthew Bingley from Global News. Matthew, please go ahead.
Hi, Dr. Brown. I'm wondering, when it comes to the slide 10, when you're looking at the projections for variants, looking at where cases have recently exploded, like Thunder Bay, I'm wondering what track you would say that they're likely on following those projections.
So thanks. I think you see the explosion in cases, you see high rates of variants of concern. The advantage, or I guess the saving grace that we have in all this is that the variants of concern do react the same way as the earlier variants to the public health measures. So if we are able to implement those public health measures, if we are able to make sure that people are able to adhere to those measures, then you actually can get that coming back down again. Obviously, cases will continue to rise for a little bit as what were infections turn into people who seek testing, but you can start to turn that around in the same way.
And I would add that the cases in Thunder Bay at this time, fortunately, have not detected any variants of concern. That is different than in the public health Sudbury and district area, which has had a rapid increase in the VOCs over the last week.
Follow-up?
Yes, and sorry for cutting you off, Dr. Williams. Again, with the ICU projections, you're talking about the backlog. Just looking at that flat line with the plateau there, well above the red line with ICU capacity, are you able to predict just how much more of a burden this could put potentially on the existing backlogs?
So if you look at the increases we've seen over the last little while in the need for surgical care, that sort of bar that keeps on moving up every period of time, with that flatlined ICU capacity, with some concerns about growth in cases, you should expect to see that line continue to move up by that same increment each time period. And were we to come back in 2 weeks, if nothing has changed and we've stayed roughly on that good course, you'll still see a higher backlog by about that amount.
Next question.
Your next question comes from John McGrath from TVO. John, please go ahead.
Good afternoon. Regarding the potential third wave here, given that long-term care has already been vaccinated and you say that it's paying off and we've seen declining deaths, is it likely that whatever the number of cases that we might see from a third wave, we might not see as many fatalities?
Comment on that. He already addressed that, but he may want to clarify that further.
Thanks. So in 2 briefings ago, I think we talked about the proportion of deaths coming from long-term care, the proportion of hospitalizations and ICU admissions coming from long-term care. Vaccinating the long-term care homes, because a large number of the deaths do come from long-term care homes, will help reduce that likelihood of death. Unfortunately, it doesn't change as much for hospitalizations and intensive care unit admissions because most of those do not come from long-term care homes. There is this concern, I think, that the new variants may be more severe, and so my optimism about a reduction in deaths proportional to the number of people who've been vaccinated in long-term care homes may need to be tempered a bit, but you should see deaths coming down.
Follow-up.
In terms of the modeling we've seen, frankly, for almost an entire year now, I was just looking at the first modeling that was presented on April 3rd of 2020, and the prediction was between 3,000 and 15,000 deaths over the course of the pandemic. Assuming public health measures were implemented. We are at about 7,100, I believe, today. Either Dr. Brown or Dr. Williams, I'm just curious, what do you make of that projection, and how do you think the modeling has held up over the last year?
You start, and I'll follow.
Sure. So, at the beginning, we actually did not know very much about this disease. The actual deaths, I'm hopeful that we're now getting very close to the end of the pandemic, but the actual deaths are kind of plotting right between our best and our worst case scenario. And that's likely a reflection of the degree to which we've had public health measures in place. We haven't had public health measures at a level of stringency that would have led to entire elimination or complete suppression of the disease. But we haven't let the disease run wild either. And so we've likely just hit right in the middle, as one might expect from those. The other thing I'll suggest is, it's very hard to kind of look 4 weeks ahead, let alone a year ahead in all of this. And the models that we show are really different ways of anticipating what will happen if you do different things. And so if you see strong public health measures in place, you'd expect to see models trend towards best cases. If you see weak public health measures in place or less strict public health measures in place, you'd expect to see situations trend towards a worst case.
And I would add, that's what we're trying to say as we have this time of observation. As we start out in this one, we were quite easily anticipating after a year in the pandemic, if we didn't do any of those measures, we were easily going to expect 50 to 60 or 70,000 deaths in the province of Ontario. While we have 7,000, and those have been unfortunate in that, and we've already expressed that, we have the collective efforts through the public health measures brought those numbers down. So those estimates, even late in April, of going up, and before the second wave, of that number was not out of reach. That was quite possible. And so as a result, collectively, with the action, we've been able to bring that down to levels that we weren't anticipating. There were plans in place to look at with similar countries that had to do that, of how to put in triaging of patients, decide who you're going to care for and not care for. The healthcare system was potentially collapsible, using areas for enlarged morgues. This was that's the part of reality of a true pandemic. It's not a light thing, and this has been hard slugging work. But some of the benefits of that, we've kept the numbers down. There's still some numbers. There always will be. That's what a pandemic is about. As I said, it's not a nundemic, it's a pandemic. And we've been able to curtail the impacts reasonably well, a lot below what we expected. And I think that's, when you see those numbers, they weren't, in my mind, huge exaggerations. They were quite tenable.
Last question.
Your last question comes from Jeff Gray from the Globe and Mail. Jeff, please go ahead.
Oh, hi. Thanks. Yeah, I just wanted to ask if you could expand a little bit on what accounts for the uncertainty in the speed of the spread of the variants. I mean, the modeling must be based on the experience of other jurisdictions. So what accounts for the range there? Is it public health measures, or is it something else?
Thanks for the question. So what we see pretty consistently is that the new variants are about 50% more transmissible, but that number does vary in studies from about 40 to over 60% more transmissible. Part of that's because we're drawing the observations from real-world situations where there may be more or less social interaction. There may be different patterns or mores of how people interact and different levels of public health interventions. So we have that little bit of uncertainty to deal with, although it is clear that they are consistently probably about 50% more transmissible. There's also the issue of getting a good understanding of how quickly they're spreading through the province. We don't know when the very first variant landed in Ontario. We do have a sense of when they started to become more common, and we try to get a sense of the acceleration there. But there are assumptions built in there, and we just need to make sure that we're always trying to raise that uncertainty and make it clear. The final thing is that it's one thing to have public health measures. It's another thing to have adherence to the public health measures. And so given fatigue with all of the restrictions that we face right now, it's sometimes hard to kind of figure out how much a measure will actually impact behavior. And we hope that it will. And where it's clear that these measures have impacted behavior, you've been able to control the spread of the variants of concern, but there is uncertainty there as well.
Follow up, and this is the last question.
And just to clarify there, that the worst case scenario, then, when you mentioned that it would be a result of a more widespread loosening of public health measures, that implies that would happen if we, say, further liberalize what we have now, or some combination of that and people stopping their following of the rule.
So in all of the models that we looked at, the worst case scenarios this time around were a combination of the high-end estimate of the increased transmissibility, a faster spread of the variants of concern right now across the province, and substantial, at the end of the day, substantial both liberalization, or it could be also a strong lack of adherence to the public health measures. They would both have the same impact. The measures, to be clear, the measures only work if people follow them.
Thanks, everyone.